Good morning, good evening, everyone. There are people calling in from India, from the US, and other parts of the world. So, welcome. And the next 1 hour is going to be quite a fascinating 1 hour. We have in today's weekly longevity lab community meet, I'll be speaking with Dr. Renu Joshi and Dr. Nirmal Joshi, co-creators of The Brown Heart. This is a pretty gripping documentary drama that confronts the heart disease crisis. I mean, we talk about this on this forum all the time. And I think this does a beautiful job. It basically goes after the biggest cause of death globally, which is heart disease. And it impacts people all over the world, but especially South Asians get impacted even more by it. And this documentary, through real life stories, expert insights, does a masterful job of explaining the what, the where, the why, the when, and uh, and so we'll be speaking to both of them. But before we get started, I want to just take care of a few quick formalities. Um, Let me just switch to the slides. I request everyone to stay on mute so that the audio remains easily hearable and audible to everybody else. And we will be having questions of both of them at the end. What I'd like to request is, please share your questions in the Google chat window throughout the talk, and at the end, I will make sure to get those questions asked of Dr. Zoshi's. Um, Now, I want to quickly, for those who have not been on this meet before, do a quick background on the Longevity Lab. It's effectively a go-to community. It's a WhatsApp-based community for what we consider credible and sustainable health span and longevity insights. Okay, and it has 5 pieces to it. There are sessions like this one we are having right now, which is expert-led sessions where we get experts from all over the health and wellness space, and we have a Q&A session with them. We have health specific programs. So, we did one on 4 key habits to build, and we do those all the time. We'll also have specific programs on dealing with how to deal with menopause, with diabetes, and so on. We obviously have a very, very interesting community because these are all like-minded people who all care about the same things. And very often I find people ask questions of each other. Hey, what's your favorite protein shake that you have? And, things that you have a group of people you can ask this question to. Personalized tools. So we have created simple tools where you can integrate your wearable data in. You can scan your foods to log them. You can ask queries of these tools. We've built them for ourselves, and now we're opening it up to members of the community. And finally, there are a lot of these health and lifestyle products, and nobody knows whether they really are credible or not. What we do is we verify them, we make sure that we ourselves would use them, and only after we do, we uh, get the producer of that product to offer it to the members of the community for a discount. We take absolutely no piece of any of this. We That's not our objective. Our objective is to ensure you get stuff that you can actually trust and believe in. And so, if you're interested in joining this community, you can join it for free. It's simple. Just scan the QR code, or Nivedita will be putting a link to it. You can click on it and join the WhatsApp community. And every Thursday at this time, we have a weekly expert session. If you don't want to sign up to the community, you can still go to our YouTube channel and check out short clips of the various talks. And you can read my blog post. It's something I write every couple of weeks, and it's also completely free. In any case, with that out of the way, I'm just going to put up the introductions to both Dr. Nirmal Joshi and Dr. Renu Joshi over here for you to read. But more importantly, I want to sort of welcome them. It's quite a thrill and pleasure to have them both on this. I can't tell you, from the week back when I first spoke to them, how much I was convinced that they would absolutely be the right people to talk to this community. So, welcome, Dr. Nirmal Joshi, Dr. Renu Joshi.
Thank you.
Thank you, Nikhil.
so
Thank you so much. We appreciate being here.
Yeah, I want to start by showing a quick trailer of the movie that you co-created. I think it'll give everyone in the community a sense for what this conversation is going to be all about. And so let me get there.
In the middle of a beautiful hike at 8,000 feet above the sea level in Uttarakhand, I had chest pain. For a minute, I thought I may not make it. जिंदगी में पहली बार गुजरने का डर लगा.
For many of us from the Indian subcontinent, time may be running out fast. A human enemy, the heart attack.
Heart attack. Heart attack. There's a rise in heart attacks among young people.
This is an epidemic.
They were talking about people of South Asian descent.
Our real journey took us to 3 different continents, specifically to India, United Kingdom, and the United States.
70% of deaths from heart attacks occurred in people between ages 30 and 60.
2.5 लाख लोग हर साल ST elevation MI से हिंदुस्तान में मर रहे हैं.
So both of us set out to uncover what is behind the staggering loss of life.
उस टाइम इतना पेन हुआ था कि ना तो कुछ बोल पा रहा था मैं.
The common thread is just how frequent heart attacks are. We spoke to some of the best heart experts in the world.
When they talk, people listen.
Diabetes, high blood pressure, cholesterol, मोटापा जैसे हमारे modern आभूषण बन गए.
Heart disease and its risk as a whole in women seems to be very, very under-recognized.
Why is it happening?
Is it our genes? You know you shouldn't be smoking.
80% diet, 20% everything else.
Some have placed stress at the top of the list of the causes of heart attack.
Habits are created by a loop, right? Cue, craving, action, and reward.
So I have lost between 14 to 15 pounds. Life is beautiful. Let's take care of ourselves better.
तो सवाल ये है कि क्या ये हमारी किस्मत है? और अगर किस्मत है, तो क्या हम किस्मत बदल सकते हैं?
Wow. I recently had the privilege to watch this movie as part of my association with the South Asian Heart Center. It'll officially get released May 3rd on Jio Hotstar. But I got a preview, and I think I got to say, you both did a masterful job of capturing the sort of the big picture as well as the subtleties, because there's a lot of detail over here, and to pull off both the big picture and the details in the way you did it, especially with the tight budgets you worked with, was just brilliant. And I think what in my mind made it different from most documentaries, that it had the pace of a thriller. I mean, you could sense the pace even with the trailer, and I think that entire 2-hour movie has that pace. You don't realize 2 hours have gone by. But it had elements of humor. It had the soothing voice of Nasiruddin Shah. And the discussion with all the top experts just made it, so credible. Especially in an area where there is so much misinformation flying around, that this, to me, is the one-stop shop to know everything you want to know about heart disease. And so I can't recommend it highly enough for both its content as well as its style and pace. So, with that, let's get started with the questions, because I know a lot of people will have questions, and I'll get things started off. To me, it's always sobering that heart disease creeps up in very insidious and asymptomatic ways. And it almost doesn't matter what the gender, age, professional qualifications, economic standing, it's blind to all of that. And as the trailer showed, it crept up on Renu. I know it crept up on me many years back. And it seems to be happening at younger and younger ages. So, Nirmal, I know you are a storyteller in addition to both of you being full-time doctors. Did this personal experience trigger the making of this movie, or given your interests, would you have made this type of movie anyway?
Well, thank you. Thank you, Nikhil, first of all. And thank you to everyone who's in attendance today. We greatly appreciate your being here. And the very fact that you are here indicates that we are talking to a very special audience who are already, in some ways, have invested in themselves, right? So thank you for being here. So to your question, what was going on? This was a couple of years ago. I had just retired very purposefully. I was just turning 60 right around at that time, just retired, and was looking at my future and really asking myself, what do I want to do for the remaining whatever length of time that I have on the planet? And said to ourselves, we really needed to give back to the community. That was one big pillar. And the second was that we would want to do things that we enjoy doing. In my case, it was storytelling, poetry, creative writing, filmmaking, all that kind of broad set of creative things. So on the first end, we started an organization called the Joshi Health Foundation, where we began to essentially see patients entirely free of charge, meaning those people who have no insurance, who have no place to go, who are perhaps the most vulnerable. But when we began to do that, both Renu and I did that. And what we found was very quickly, it was super rewarding and continues to be super rewarding, by the way, today. But we said, you know what, we need to impact more people, meaning we need to, with one stroke, putting all of our energies together, we want to impact more people. And then right around that time, two things happened. And I'm going to turn it over to Renu to share both of those things that led to then the starting of the Brown Heart journey.
So we, as we were sharing with Nikhil, we have been doing community service with lectures for the last 20 years, where we'll have 100 people in one room and we'll talk topics 3 times a year. And we've done that for 20 years. So as Nirmal said, our goal was how do we reach higher? But at the same time, we had taken a trip to India for actually my daughter's engagement in Bombay. And then we took a trip to Mukteshwar, which is our hometown, Nirmal's hometown. And we were at a hike at 8,000 feet. And right before that, I must tell you this, that I've had a great cholesterol. I've been a faithful exercise person for the last 30 years. I have always ate healthy for the last 20 years, 25 years. So there was really no risk factors, no family history of heart disease, no diabetes, no hypertension, smoking, you name it. Did everything good to my life. And then as menopause came in, even though I was taking estrogen, my cholesterol started to creep up on me, but still in the normal range. By no means it was high. And my PCP was telling me, you know what, you might consider statin. And I said, with a person as healthy as I am, I will never go on statin. So I will just do it with diet and lifestyle. And then she said, okay, let's do a CAC score and see what happens. If the CAC is 0, I won't come after your life. So we did a CAC score. And as Nikhil has shared his story with you, my CAC was clearly positive and a lot. And I was really worried what happened to me. And within a month, when I was, after that, we had gone for a hike. After starting statin, of course, at 8,000 feet, I really had chest pain. I had nothing with me. And I was really worried that, I may not make it. A thought really crossed my mind. So make a long story short, I was diagnosed with heart disease. Luckily, no heart attack. And I have not required a stent. And my goal is that I can keep it like this without a stent. So that's what started. We were already thinking about doing something big through the foundation. And with Nirmal, he's been a storyteller. He has done a book. He has done short films, amateur films for the last many years. And we thought, let's put it together. And one of the things which came across was when we did research that actually the heart disease has been in Indians for the last 50 years. But even I, as a doctor, did not know much about it. So I said, my God, the public absolutely does not know about it. And that's where the Brown Heart journey was born.
And I think I'll just add one thing to what Renu said, which was right around the same time, we had 2 very close friends right here in our community in their early 50s who had, and I was at their bedside, at least in one instance throughout the process, scary as heck, again, very healthy, who developed heart attacks and who ultimately got an open heart surgery. Both of them had quadruple open heart surgeries. And so adding to Renu's point is that we were totally driven at this point. We've got to do something about it. So I'm going to pause there and let Nikhil continue the conversation. Oh, you're on mute, I guess.
Sorry, yeah. Thank you for sharing that, Nirmal and Renu. I think, the 2 friends of yours who had a heart attacks, I would still call them the lucky ones, because
Yes.
they survived.
Yeah.
And I think that's the part that I read an interesting statistic that about 30% of people find out for the first time they've had a heart attack or that they had heart disease after they're dead.
Yeah.
Because those people were not as lucky. The first time it got them, it got them. And given the high proclivity of South Asians, we really need to almost assume we have it and, disprove the hypothesis. And so, given this comment you made, Renu, which is you're a doctor, and yet, you did not see this coming. Now that led you on this path, and from what I understand, you did a ton of research together. Can you just talk about that whole process of, researching for this movie?
Yeah, absolutely. So being doctors, we are used to asking ourselves, we are used to saying to ourselves, I don't know, right? And being, and when patients ask us questions, we're the first ones to admit that we know very little. We know probably 10% of what needs to be known. So every single time when a patient, and Renu is in the same boat, I know that, when patients ask us a question, we go back to the primary evidence. We're always taught to go back to, show me the evidence, show me the data, show me, and you being a scientist, Nikhil, will certainly understand that go back to the evidence and then look for the quality of evidence as well, not just evidence, but the quality of evidence. So the first step was go back to basics. I said, I've got to do, and we said, we've got to do, we have a whole stack of articles sitting here in my back here, literally this big, because I still like to print out and make notes on the articles, right? Unlike, the more digital natives who love to just read. So we pulled every single possible thing through PubMed, through NIH, through every possible source that we could get. And it was funny that multiple review papers got us to the same kind of endpoints. And as it always is, it's a handful of people who dominate the space when it comes to producing research, right? And then right around that time, we'd had Dr. Alka Kanaya, who's the principal investigator for the Masala study in San Francisco at UCSF. She had given a lecture to our community on the Masala study findings in Asian Indians and early heart disease. And needless to say, Alka was featuring as a frequent flyer on these articles, in addition to other people. And before we knew, the wonderful person as she is, and over the last 4 years has become a super nice friend of both Renu and I, is that she literally single-handedly connected us with key contacts across the world, right? Hey, talk to this person in Birmingham, talk to this person in Scotland, talk to this person in Chicago, talk to this person in Pune, Dr. Yajnik, talk to this person in Delhi. She had connected me before I knew it to about 12 people within a matter of a week. And the very next thing I said, you know what, it's time to do this documentary. And that's what set us off to all the 3 continents and talking to over 40 different people and putting together about 110 hours worth of interviews. Fascinating journey. I would never trade that for anything. As I look back, it's been one of the most pleasurable periods in my life, between the foundation taking care of people who are vulnerable and this. It's been one of the most pleasurable times in my life, one of the most rewarding.
And as you will see in the documentary, that you will see sometimes contradictions, because one person said this, the other person said, no, this is not the truth. This is how it is. So we went back to the articles, looked at the evidence, and then we presented both evidence. So people know for sure that this is what's happening, because obviously different countries had different take on different things.
Yeah, no, absolutely. In fact, you took 110 hours of research and boiled it down to a 2-hour documentary, right? I think the editing job itself must have taken months.
In fact, the editing is what...
Editing took at least, oh my gosh, I think we probably pulled each other hair so many times that we were ready to fight and stay away from each other for many days, because we were constantly saying, oh, this line goes in, this line doesn't go in, this goes in, this article goes. So, yes, we started editing in March. So as you can imagine, this is now, we are talking about next March. So it's been a year editing the process. Yeah. And we took first thing we did was took all the interviews and we marked what lines can we take. So it was like each hour of interview had 12 lines which we could take. And then those 12 lines eventually got down to 3. because we had to cut out so much.
Yeah.
But it was a very tedious process. But we had a full set of people in India who are the editors, but being a medical documentary, the content was ours. We were still telling them what to do because the content was ours.
Yeah, and I think I would add to that I think that one of the things that was a constant dilemma, right, was the pull between the yin and the yang of evidence, hard evidence versus human stories, how much of representation for each. And given Renu's presence, I think what happened repetitively is she would push back. Every single time I would go in favor of evidence, Renu would push back in evidence of or in support of human stories. Human stories ultimately trumped every single time we talked about it. Human stories trumped. It had to be backed by evidence always, but human stories always won. So you will see repetitively, and I give full credit to the one sitting here, every single time human stories won.
Yeah. And, given what Renu said earlier, that we all pulled each other's hair, she obviously won.
For sure.
So, actually, that brings me to a question that I've struggled with, because we talk about this a lot. The whole calcium CT scan, right? In many ways, that is, Renu got her CAC score as the way the doctor decided whether to give statins or not, right?
Yes.
And we recommend that a lot. But in the US, given the insurance system, the number of times people come back to us and say, well, I went and spoke to my doctor. Either my doctor didn't agree or my doctor agreed, but insurance said, no, you have no symptoms. But given that it's asymptomatic, this whole thing is just a very weird setup to look for evidence or symptoms when it's fundamentally an asymptomatic disease. How do you deal with this?
So the bottom line is, yes, it is very hard even now to get it covered by insurance, even though the evidence is there. But if you know, the evidence translation into the real world takes 10 years. So the data is now coming out. So hopefully in the next 5 years, the insurance company will be at par with it. We don't know yet. But one of our goals is that with the documentary, if there's enough people who know about it, then our goal may be to present it to the insurance company in this way. That, hey, you're going to save lives, why not? But till we get there, it may be another 5 years. The CAC score in here takes only in some places, I can't say for every place, but it costs somewhere around $99 in this country and 4,000 to 5,000 rupees in India. So given the amount of money we spend on other things, I think in the big scheme of things, it is not as bad. Now, a question still comes that whether a PCP is going to write it or not.
That's the primary care provider.
And that's the primary care provider, whether they will write so in India, it's much easier because people can walk into it and get it done and it's not a problem. Here, it does become an issue. So in our community, what we started to do was, hey, if nobody writes it, call us and we'll write it for you. But obviously, you don't have a doctor in every community who can do that. But ultimately, it is convincing your PCP. And I also believe nowadays, because I'm an endocrinologist myself, and patients come to me and they demand it. And they said, we need it. I'm going to pay for it. All you have to do is just write it. And I do end up writing it. If you're taking care of your health, what is wrong with me writing it as long as you are paying for it? So I think patient is your best advocate and you have to be your best advocate. I have family history. I want to do it for myself. And I think you will get there eventually. And our goal, as I said, maybe in 3 to 5 years or even sooner, we will be able to convince some insurance companies to pay for it.
Yeah, no, fingers crossed. Absolutely. It's the need of the hour.
Yeah.
There is a lot of misinformation. We spoke about this earlier as well. The number of WhatsApp forwards that I'm sure you all get. I get a lot of them. And how do you sort of navigate that when you talk to people who send you these WhatsApp forwards that are completely wrong, but they ask you this question, should I believe this or not? Is there some sort of a framework, some sort of a thought process you would recommend to people on how to tell the difference between what's completely fraudulent, misinformation, disinformation, and what's actually legitimate?
Yeah, no, I think that's a great question, Nikhil. And I think that's something that we as physicians struggle a lot with, quite honestly. And we sometimes really bite our tongue when we look at WhatsApp forwards that come to our own communities where you go, even doctors, my fellow physicians sometimes forward these things who have not, and both in India and here, this is an equal opportunity thing everywhere, right? Where some physicians, they've been so out of the evidence realm for so long that they depend either on the media or they depend on other sources of information on how do we actually, navigate this. Now, there is unfortunately not an easy answer, but what I did a couple of years ago, and I'm actually, give me 1 second, I'm going to post this at a later time. Your listeners can refer to this YouTube video. It's a 6-minute video that I had done about 3 years ago, maybe actually 4 years ago, right around COVID, when there was so much misinformation spreading at the time, and the differences between disinformation and misinformation, and how do you actually navigate all of that. I put some markers as to how you distinguish. So because it's such a large topic, I'm going to just post the video, and there is also a written piece to it, which I'm happy to send to you. It's on our foundation website and everything. I can send that to you as well, but I'll summarize it in 2 lines for right now, which I had a mnemonic there that I created that I called the PAM mnemonic. Okay, PAM. P stands for pause, A stands for analyze, and M stands for make it your own. Pause meaning please don't forward something. Stop right there. Say the urge is to press the forward button because intentionally the post is meant to generate an emotion. Wow, I didn't know this. It meant to sensationalize medical information, which almost is never sensational, is almost always somewhere in the middle, right? So pause, analyze meaning you go around and look, and we mention specific tricks. For example, if there is more than one source that you can find that corroborates that information, it's more likely to be authentic. Secondly, the quality of evidence. For example, URLs on the web that have a .org or a .gov, .gov are more likely to be credible and not have misinformation. And websites such as WebMD, Mayo Clinic, Cleveland Clinic, reputable websites, and in India there are several as well. When you have those, they're more likely to be credible. Anyway, the last one is to make it your own, meaning you synthesize this information and then decide to forward if you do. Ideally, don't even forward it, but if you're able to at that point. So I hope that helps. And I think the YouTube video and the accompanying written format will help you figure this out better.
Yeah, no, that's actually a wonderful framework. And in fact, if you can send that article as well,
yes.
Nirmal, we'll put it onto our community for people afterwards. If whoever couldn't attend this can still click on those links.
Happy to do that. It's already here, so we'll certainly do that.
Yeah, perfect. Moving on, as you were going through this journey, and I know the film covers this, what were some of the most unexpected things you uncovered through this? I'm sure there was a lot, but what made it to the top? Like, wow, I had no idea that this was also true.
So,
visceral fat and low BMI. So I can start, then Nirmal can talk a little bit more. So the 2 things which we really covered, and not that we did not know, but we did not know at this extreme, that number 1, the Indians get heart disease with a normal BMI. So we are typically not heavy or obese, but we get diabetes 10 years earlier than our counterparts everywhere else, and at a very thin BMI. And I also learned, because we've used BMI tool for a long time, the BMI doesn't work for Asians. I do know that the American Diabetes Association has now cut down the BMI to 23 for Asians and not 25. But even at 23 BMI, like me and you, we did get heart disease. So BMI is really not a marker anymore. Waist circumference is more of a marker. So that's something we really learned as a new thing, which we were not aware of. And then obviously the whole concept of now with millet versus rice and the inflammatory diet, which is again a new concept in the last 4 years, that diet which carries more inflammation causes more heart disease. So heart disease is never thought to be inflammatory disease, but now it is. So if we eat more inflammatory products, then we are going to get more heart disease. And I think that also changed. I mean, we were changing our lifestyle anyway, but even changed more based on those data. So those were 2 things I learned.
Yeah, and from my perspective, it was fascinating to me. The more time I spent with experts, the more I kept going back to basics. Meaning, it's not, so if I were to sum it up, I would say it's not rocket science. It's pretty basic stuff. The surprises, and I wouldn't even call them surprises, were just the extent and the severity of heart disease in Asian Indians in general at very young ages, 10 years younger than our American counterparts and so on. So that was a surprise. But then as I kept going around, like Renu said, this whole concept of inflammatory foods came as something that was a whole new world to me. And the more I learned, and thankfully right around that time, at the All India Institute, as I walked around the corridors at AIIMS in Delhi, so the people who are part of the Mission Delhi program took us to a cafeteria, right, to the hospital cafeteria, and I took a picture of it, which I'm happy to share. The name of the cafeteria is called the Millet Cafeteria now, right? Everything in there has grains that are more millet based. Now, I'm not one to tell people, hey, do this in diet, a single thing will change your life. I'm not one of those. I always tell people you've got to balance, you've got to incorporate different things. The point I'm trying to make is the whole concept, which one of the folks there has actually written a book on, it's called The Indian Adaptation of the Mediterranean Diet, which I thought was fascinating. So those were a few things that came out that stood out for us as going, wow. And to really make a long story short, and then this is not a spoiler alert when I say this, toward the end of the film, one of the things we talk about is that really the story, the unlocking of all of this is one thing, which is a simple life.
Right.
And in fact, we were just talking, we were in California doing our screening, and I think your listeners will get a chuckle out of it. So that's why I mentioned. So I was on my carpet doing my back exercises in the hotel. And we were just laughing that, oh my God, 2 years of hard work is paying off. And he was saying, what next? And my answer is simple life, doing nothing.
Following your own advice.
Yeah, following our own advice. Exactly.
Yeah,
Exactly.
yeah. One of the things that I learned through my journey along these similar lines is the role of, how much importance we give to cholesterol. Right, but we do not give enough importance, and now this is becoming more and more clear, to things like ApoB and Lp(a), right? And that's in the documentary as well, that how much those two. There was this interesting study done in New York where 20,000 people who had a heart attack and were admitted to ICU, about 30% of them had a LDL cholesterol level below 100. And so that in itself cannot be a marker to decide, right? And so ApoB, Lp(a), now more and more, if you're willing to push your insurance, they are willing to do this. But for a long time, they were not willing to do it.
Yes.
No, but Lp(a) and ApoB, again, for your listeners, is now commonly done. And you can ask any doctors. This is called Advanced Lipid Panel. In India, you can get that done for 1,000 rupees. And they do everything under the sun. And even here, there is now called an advanced lipid panel, which my cardiologist did on me. But anybody can ask for advanced lipid panel, especially if they have any family history or they want to lead a better life.
So I've had friends in the last 3 months in California who their doctor said, why? Why do you need it?
Yeah.
So my point is, even now, even in a place like California, in India, it's the easiest. Nobody cares. You ask for it, you're willing to pay for it, you get it. Here, the doctor has to approve it, then insurance has to approve it, and that just makes things unnecessarily complicated.
And that goes right back to the original premise, which is, as informed consumers, our job is to be able to pull those as a consumer now, not as a doctor. Pull those articles, take them to your doctor and say, hey, here's the data.
Exactly.
Patients do that to me all the time. I don't get offended. I welcome them to do that. And then I say, you know what, thank you for giving this. I'll spend a couple of days and get back to you.
I actually my American cardiologist to come to the documentary screening, which we did here. And he wasn't coming. I said, no, just come. And when he left, he said, oh my gosh, I thought I'll just stay for half an hour and leave because, but I am glued to my seat. I learned so much from this documentary that I didn't know about South Asians before.
Right. And this is a cardiologist.
He's a very good cardiologist, one of the best cardiologists in town.
Yeah. In fact, that does bring up another very critical point, and that is the rate at which medical science is progressing is only accelerating. And practically for any doctor, however motivated to keep up right, with all the research is so hard. And so I think this is something that, having a doctor who sees patients, but also has time to set aside to keep up, that to me seems to be the trick.
Yeah, absolutely.
Yeah.
Right. There are a lot of questions coming up, so I'll try and maybe move over there quickly. But before we do that, I thought maybe one fun thing to do, and it might answer some of the questions, is this rapid fire round.
Yeah.
Okay. I'll throw out one of the things that is spoken about often, that people always have questions about, a one word or a small short phrase, and you give on a scale of 0 to 10, 10 being absolutely go ahead and do it, and 0 means don't bother, it's a waste of time. Wherever you have to provide a little bit of context, because I'm sure there are some places that will be required, go ahead. But I've got about 8 or 9 of them, okay? Number 1, statins.
10.
So there's no need to talk about evidence. We have already spoken about it. See the documentary and then come back to us and we'll answer more questions.
Yeah, exactly.
And by the way, we have no stock in any company, just so you
know. Number 2, GLP-1 drugs, but for weight loss less than 10 kgs, not for the people who are very diabetic. But
okay, so this I'll take because I'm an endocrinologist and obesity expert, because that's what I do for life and living. So I would give a 5, because normally I don't think I can give a 0, because there are people who have tried everything with diet and exercise and their BMI is still not budging and it's above 25. So there's a room for GLP-1. But remember, the drugs can only lose the weight when you're taking them. So when you stop the drugs, the weight comes right back. So that's one of the problems which people don't realize. GLP-1 drugs, the reason I don't give them 0 is they have very good data coming for cardiac improvement and saving lives. So independent of losing weight, they're actually making some changes in cardiac inflammatory markers. So it's actually improving cardiac health. So it's not wrong, but typically we start with somebody with a BMI above 30, 32, 34. Those are classic case for GLP-1. Between 25 to 30, 25 to 29, I would first try diet, exercise, and everything else. And if somebody is really stuck, give GLP for short time and then take it away.
Perfect. Strength training.
About an 8.
Yeah.
And the reason,
yeah, well, the reason is for a whole variety of reasons that are both cardiac and non-cardiac. Non-cardiac, most people know, right? We are terrible as Indians. We are terrible at strength training. Many of us have at least begun to get into aerobic exercise, but many of us are very poor with strength training. So the cardiac benefits, however, we learned some of this during the documentary, is that not only strength training improves muscles, it also lowers visceral fat, which directly has a positive impact on cardiac prevention.
Got it. Protein and the importance of protein in your diet. Do South Asians get enough protein in their diet? Right?
Not at all. It's 10 over 10. The first thing we need to do is get more protein, whether you're vegetarian or non-vegetarian. And you have to get healthy protein, not unhealthy protein.
Yeah.
So I would give a 10 over 10.
Okay. There is this interesting thing that is being discussed in this longevity groups. Okay. And I put longevity groups in quotes because sometimes I think that's an excuse to do crazy things. Metformin for non-diabetics, Renu.
Okay, so I'll take that one. And the reason is metformin. If you have pre-diabetes, which is between 5.7 to 6.4 A1C, and again, we don't have the time to get into those details, but the normal A1C, which is the test for diabetes for 3 months, the normal is less than 5.7. Above 6.5 is diabetes. So if you have an A1C between 5.7 to 6.4, you are pre-diabetic and you have an 11% risk of becoming a diabetic over the next 5 years. Now, the data does show, again, medical evidence shows that if you have an A1C of less than 6, your risk of diabetes progression is very small. But if your A1C is above 6, between 6 to 6.4, then your risk of diabetes progression is higher. So in those populations, when the A1C is above 6, along with full-time diet and exercise, I would add metformin, especially if they're on the heavy side, so I can have them lose some weight. And the reason to do that is pre-diabetes, the clock of the heart disease start ticking at pre-diabetes and not diabetes. So by the time you become diabetic, it's already too late for the heart.
Yeah, makes sense. And by the way, again, in light of logic not always being very obvious, is in the US, for a long time, they did not prescribe a CGM unless you are diabetic.
Yeah.
Right?
Yeah.
Like similar challenge, right?
Absolutely.
So one of the things you can do for that, both of them have a website, and you can actually go for a one free coupon. So if you go on their website, they'll give you one free sensor for 14 days, and that's enough to give you the data.
And now actually, in the last few months, maybe last 4 months, they have now gone direct to consumer. Now, no need for any of that. So you can just directly get it. All right. I have a few others, but given the long list of questions, maybe we'll switch to the questions.
Sure, absolutely. That's always the fun part. Yep.
Yeah. Let me sort of take them in the order that they came. All right, there are a lot of AI assistants I have to turn off. Okay, I know we've spoken briefly about this, but if there are 3 to 5 markers that you would recommend, whether they're blood test or body composition, what are the 3 to 5 that you would highly recommend in addition to the standard ones?
Yeah, I can take some of that. So when we say markers, I don't want to just get into blood work, right? Markers meaning, what do you want to do to be able to screen yourself, if you will, or be motivated to change yourself. So that's how I look at these, right? Markers in establishing a baseline. I absolutely want to know a few things about myself. I want to know what my BMI is, even though there are limitations to the BMI. Very quickly, I want to, right after the BMI, in the same breath, I want to know my waist circumference. More than 90 in men, more than 80 in women. Centimeters indicates you're at a high risk. Third, I want to know from my own body's perspective, a regular lipid panel, and I want to know an extended lipid panel, my ApoB and my lipoprotein A. Ideally, I personally would want to know my CAC score as well, although there is some controversy around that as to what age you should begin and so on. Most people agree that starting about age 35, you should get at least one measure of CAC score. One of your listeners asked, do you have to repeat it? The answer is, in most instances, no, right? Because the repeat testing, we don't know how to interpret it in real ways. Similarly, with LP(a), you don't need to repeat LP(a). This is not like an LDL or a cholesterol where you do repeated serial testing. Just one time, and if you are over, depending on which lab you look at, 25 or 50, if you're over that, you are at a higher risk, particularly if you're a South Asian, and you need to be doubly motivated to change yourself, right? So that's that. And then, so the CAC score we've talked about, a single measure is good enough, and I'd like to know that. We repeatedly say in the film, although there is some question of a less than a 10 CAC score, I believe in every South Asian, we need to be so aggressive, we need to be ahead of the curve with evidence. Now, this part is my opinion. Any CAC score more than 0, I say to people, you need to be more cautious. Anything more than 0. 0 is clean. And then, so these
and a blood pressure,
and of course your blood sugar and
the blood sugar.
Those two are, and there is a very nice, in the film, we have a very nice thing which we call the human cockpit, and we're going to put that up on our website as well. So later on, your listeners can go back to the website, thebrownheart.com. We'll have the entire cockpit laid out just like it's in the film, and that all of this will be live on May 3rd.
Yeah, perfect. Now, somebody's asked the question we've answered, how often should one do the calcium test? And I just wanted to add to your answer is, if your score was 0, and then after what we are talking about in our communities, maybe every 5 years to 7 years, you should do it. It's not a bad idea to do it every 5 to 7 years. If you are taking statins already, then there isn't much value in doing a test again, because statins in many ways actually increase the calcification, but they just make it more stable, right? Absolutely. And so I think that was sort of
so Nikhil, if I can comment, I want to corroborate and reinforce what you just said. If there is a negative score, repeating is actually not a bad idea. And secondly, if you're already on a statin and your LDL is less than 70, right? You're already doing the best you can do from a statin, from a cholesterol standpoint, right? So there may or may not be merit, if you're already on that, to do much by way of risk stratification at that point, because you are ahead of the game.
No, as you said, because the calcium score does not go down, it just gets stabilized, so you don't get a plaque blockage, you don't get a plaque, what do you call, destruction of
rupture.
the plaque, rupture,
Rupture,
and get
yeah.
a heart attack. So, yeah.
Yeah, perfect. I've read and heard from some people that indicate statins are effective for men, but not for women.
Not true.
Not true.
Yeah.
My
and this
LDL is now 58, but I'm on 80 milligrams of statin.
80. Wow. Yeah.
Once you have cardiac disease, you have to be on a full dose.
Yeah, exactly. And so the thing that, and a lot of questions are on statins, and I think that's not surprising, given
Yes.
the amount of misinformation about statins.
Yes, very
I mean,
much.
I know how many questions I get about statins, and I'm not even a doctor, right? But because around the community, that's why people come. But I think it can be said very comprehensively and clearly. Statins are one of the most studied drugs in the world, right? There is so much evidence. It works well for men and women. And there is, the only downsides are sometimes there is some muscle pain for about 3 to 5% of the people. If that happens, you switch to a different statin. That's all. And some other statins, sometimes they can increase your HbA1c. In my case, I know mine increased it a bit. I just, made sure through lifestyle interventions, I got that lower. So if those are the only two downsides, they are very small compared to the upside that they give you. So anyone on this call who's thinking about, should I be taking statins? If your LP(a) is high, you really should consider it. And everything else that was already mentioned by both Dr.
And
Nirmal
just
and
two things for statin. Number one, you always should check your vitamin D, because if you get muscle aches and pains, 90% of the time, because all South Asians have low vitamin D, so take high dose of vitamin D to get your D level above 40 or 50. And the second thing which really helps with some statins is coenzyme Q. So CoQ10. So if you can take CoQ10 with statin, many times your muscle pain goes away.
Yeah, perfect. Sanjay had a question. My GP's logic for me not taking the calcium test is that I'm already on 10 milligram of statin. A clean 2D echo and stress test is that the calcium score would not give anything additional.
So I think that there is some merit to what he's saying. That's not, by that I mean, if you're already on a statin and your LDL is less than 70, it's a little more questionable, if you will. Personally, the way I look at the CAC score is I use it as a motivator for myself to be aggressive or very aggressive. You should always be aggressive as a South Asian with heart disease. The question is whether to be aggressive or very aggressive. And very aggressive is if your CAC score is anything more than 10, by God, it motivates me every single day to kind of go out there. If I'm feeling lazy in the morning, not exercising, I remember the CAC score of 200 and some that I had, and I go out for a run again.
Yeah. I think that's a very, again, if you visualize this,
yes,
it makes it a lot more fun.
Yeah, exactly.
For people with cholesterol above 200, is statin compulsory? And I think, again, I want to just add a comment here. To me, this whole point of total cholesterol is actually quite a useless metric, because you're adding one supposedly good thing, HDL cholesterol, with one supposedly bad thing, LDL cholesterol, and adding them together and trying to make sense. Because I can get 200 with 100 LDL, 100 HDL. I can get 200 with 150 LDL, 50 HDL. So I don't think one should use total cholesterol as any way to decide. It should be based on the points made.
Absolutely. And I just add to that, it's not really a combo of HDL and HDL. There is a complex way to calculate the total. However, all the other logic that you said, all of the guidelines, all of the criteria, all of everything is based on LDL and LP(a).
Yeah, exactly. So I think, Deepa, you had this question. I would say, don't look at the total cholesterol, look at your LDL, which you probably already look at, but in addition, look at LP(a) and ApoB. If you don't have that measured, ask to get those measured. There is a question about, would you generally recommend Repatha over statins for women?
Yeah, great question. I take Repatha, by the way. I use Repatha myself for the last between Repatha and what is the other one? It's the same. It starts with a P. It's a PCKS9 inhibitor, is what Repatha is. For those in the audience who don't know what that is, it's a relatively newer class of cholesterol lowering medications that are available by injection only. I've used them for about 8 or 9 years now. In the US, they are extraordinarily expensive, about a few $1,000s a month. And most insurances don't cover them. Because I was intolerant to 6 different statins, and I took statins for about 18 years. After that, when I was intolerant, I absolutely wanted to go to something else. And then I went on. They're highly effective drugs. My LDL literally in 2 shots dropped down to in the 38, 40 range at the time. Since then, I've adjusted the dose, and I stay between 50 to 70 most of the time. But men and women, no difference. Wonderful drugs to lower cholesterol. And I think with time, they will become even more as a preferred agents. As the cost drops, they will become more of the preferred agents to lower cholesterol.
Yeah, perfect. And typically with statins, most doctors also prescribe aspirin, some sort of blood thinners.
Yes.
And that's the standard, right? There's nothing
no,
to
absolutely.
worry about.
No.
Not for primary
Yeah.
prevention.
No, he's
aspirin,
saying the combo is okay.
The combo is okay, but aspirin is now not recommended for primary prevention. So if you do not have heart disease, you don't need aspirin. You just need the statin. But if you have the CAC score, or if you have positive heart disease, then of course the aspirin is required.
Yeah. And so Nitin, your question about aspirins, blood thinners, it's always in the context of if it's given together with the statins, it's perfect. Don't take it by itself.
Yes.
In fact, they do say if you're getting chest pain somewhere, and India, there's a lot of these combination pills around, they tell you to take aspirin, Lipitor, and isosorbide nitrates together. And that's not a wrong thing. That's a good thing to do.
Yeah. So always in combination.
Yeah.
Okay. I'm going to combine Uday's question with one other question that was asked earlier. And that is, there are so many things you talk about in the film that together have a positive impact, right? In terms of our lifestyle. Are there, again, a couple of things that you would say, hey, do everything, but really, really make sure you do these 3 or 4 things? What would those be? There is no silver bullet, but within that.
Absolutely. I think that what we learned was that like I said, getting back to basics, diet and exercise. And I hate to say this generically, so it's important as a qualifier. What do I mean by diet? So diet meaning if you took everything together, I think one of our biggest culprits in Indian diets is carbohydrates, particularly primary sugars, right? Growing up, we were always taught, mom always gave us fruit juices. Mom always gave us, if you could take more calories, it's a good thing. Turned out almost all that paradigm has changed so that primary carbohydrates are really, in my opinion, the biggest killer. And in my opinion, many of them overlap with inflammatory foods, whether it be polished rice, whether it be orange juice, whether it be other juices and primary sugar, potatoes, and so on. All of those are inflammatory. Beautifully, the other extreme, Indian spices are actually anti-inflammatory. Jeera, dhania, haldi, all of them are anti-inflammatory. So that's a wonderful thing. So that's one. To me, diet is 1, 2, and 3, eliminating primary sugars and simple carbs. Exercise is the next 3. Starting from the lowest end of the spectrum, walking a little bit after a meal, at this end of the spectrum, to doing aggressive high-intensity training every single day with some strength training thrown in regularly is the other extreme, this end of the spectrum. To me, those are the 2 biggest things. And thirdly, if I were to bucket everything, know your body and know your risks so you can attack it.
And I will also add stress to it. So I think that is my common thing, which I talk to all my patients as well who are pre-diabetic or diabetic, that if you're not able to take time for yourself, you're not going to do a good job at work. And I think you will learn from the documentary how much of a part stress plays. And actually, there's medical evidence behind that. So I think that is the fascinating part, which we learned with the documentary. So I would definitely put stress. And for that, every person, I think, can be benefited by just 15 minutes of meditation every morning. Take that time out from your life. Give that to yourself. And I think you'll start off with a much better day.
Yeah. And I want to make a couple of comments on both the points you made. One was stress. Let me start with the stress point. I read this interesting study that showed, you can take care of your insulin sensitivity. from your food, your exercise, and do a great job. But if you have stress, the cortisol will undo all the benefits you got with doing stuff right. So just eating well and exercising by itself is not enough if you are going to constantly live a stressful life, right? And I'm assuming that is true, right?
Absolutely, 100% true. And I'm going to just put this in the reason you see me a little distracted is I'm going to put this in and this is part of the film as well. And we stress this a lot, this mnemonic that we call Swades, that I've put in the chat. Stop smoking, watch your weight, assess your risk, diet, exercise, and stress and sleep. So again, a lot more detail in the film, but I've just put it up there to remember.
Yeah, no, that's great. And then the other point that I think was along with this question, and I think the answer may already have been given, but the Ayurvedic diet, that's another topic that a lot of people who follow the Ayurvedic way of living. But I feel like that is another way of saying get back to the basics.
Absolutely it is. And I think I say this all the time. I value a lot of our Indian traditions and what they bring to the table. They bring a simple life to the table, whether it be good vegetarianism, whether it be some of the Ayurvedic things that are out there. I have a lot of respect for them. That being said, I sometimes worry because I don't know. I simply don't know. Some of the Ayurvedic things I just don't know enough about. And occasionally I worry what goes in the name of Ayurveda, if it has stuff in it that has, I know, well-defined side effects. So what I tell my patients is, whatever you decide to take, just show me what you're taking, right? So I can look at it, and sometimes I have to go back to my natural database, natural drug database to find out, because I don't know, So with that caveat, I'm always very respectful of what Indian methods of prevention bring to the table.
Just don't do contaminated vegetarian, which is samosa, pakodi, and jalebi and all that. Just don't do that.
Yeah, no, but I think you made another very important point there, right? Which is sometimes I can just put the stamp of calling it Ayurveda, though it's not really. How do you know? If most of us see Ayurveda's suggested things, we'll take it at face value. And so let's all make sure it really is what it says it is, right?
The only
somebody had a question. Yeah, sorry, go ahead.
No, I think just a quick thing. I think somebody did just ask, should we be tracking our cortisol? No. I just want to make sure that we don't check cortisol because it may not help.
Yeah. Going to another question somebody asked was about the inflammatory foods. I think you have definitely increased awareness through this talk. And, I'm pretty sure each of us is going to need the list in the context of what we eat.
Absolutely.
And so if you're already part of the community, please post your questions there, and our team of dietitians will post examples of inflammatory foods. And if you're already using Kai, our WhatsApp-based tool, you can put that question in there and it will tell you whether it's inflammatory or not if you put in what you typically eat.
And also, if you have any more questions which are left, we are happy to answer them later on as well.
Yeah. I think we're pretty much coming to the end of our time. I want to ask a couple of quick other questions. There's a question from Salil about what's your view on a 24 or 36-hour fast and its impact on heart health?
Okay. Yeah, sure. I can take that. So intermittent fasting, I practice intermittent fasting, a slightly modified version of intermittent fasting. It's extremely good data with one caveat. One caveat meaning ensure that you take adequate protein. Just make sure you deliberately take more protein if you're intermittent fasting. Those are the instances where the slightly higher mortality in one study was detected when there was not enough protein. That being out of the way, there are multiple ways to intermittent fast, all of them found to be quite effective in reducing weight in the short term. I typically like the most moderate of them, which is a 16-8 method, which is 8 hours of dukaan khuli hui hai, and then 16 hours dukaan band, right? And then I began to have serious problems with the 16 hours. So I have a 50-calorie little drink in the morning because I get headache and hypoglycemia if I don't. Other than that, intermittent fasting does work and has pretty good data on both weight reduction, waist size reduction, and cardiovascular
And the
health.
question came for 24 and 36-hour fast. That's one of the extreme ways of weight reduction, intermittent fasting. There is data on that as well. It's just very hard to continue. Very hard to continue. So you don't eat anything for 2 days and then you eat for 5 days. So it becomes a little difficult.
Yeah. And I want to add to this comment about protein, right? I mean, one thing that we talk about in our community is, unlike carbs and fat, our body has the ability to store carbs and fat. Protein, it does not have an ability to store. And so if you don't have it, we can't say, yesterday I had a lot of protein, so today I'm fine.
Yeah.
Today you require, otherwise you start losing muscle mass. And that is something we cannot afford to do once we are past 40. You have to hold on to muscle mass and,
as you can. Yeah.
As much as you can. Right? I know, I think there are a few other questions, but I think we have to stop. And in fact, what I would love is, once the movie is out and everyone on this group has had a chance to watch it, I'd love to have both of you back, because by then the questions might be different, but I'm sure it'll be as fun and exciting and fascinating a conversation as this one was. So I want to thank both of you for taking this time. I'm really, really glad you said yes. And I can't wait to have you back. I want you all to end with, where can one watch the movie?
Sure. So first of all, thank you so much on behalf of both of us for having us here. And I can't tell you how much I appreciate, particularly talking to an audience like this who is so connected with their health. So thank you. And as far as the movie goes, the movie releases on May 3rd on Geo Hotstar. So we are very actively and eagerly waiting for that. So that's only in India. For those of you who are in the United States or anywhere outside of India, the movie will be on YouTube, which will be thebrownheart.com will be the website where you'll be able to find it and track it and see it. But in India, look out for Geo Hotstar and
spread the word.
And then spread the word, please, please, please.
Yes. Yeah, because each one of you can tell 10 of your friends to watch it. I think we'll save at least one more life.
Absolutely. And way more than one, I'm sure. Yeah. But thank you again. And guys, we are done with today's session.